Hello everyone, welcome back to my channel. This is Med Classes tutorial and thank you so much for the support on my first video. In today's video, I will be sharing about hyperthyroidism. So make sure you watch till the end. If you enjoy the video, don't forget to like, share and subscribe. So before discussing about hyperthyroidism, we will discuss about the definition and what are the etiology, and we also discuss about the pathogenesis and clinical features and their management that will be asked in your theory exams. So, hyperthyroidism is a condition where there will be an excess synthesis of thyroid hormones, that is T3 and T4. Thyroid hormones will control the metabolism, heart rate, body temperature, etc. So, etiology of the primary hyperthyroidism or Graves' disease is the most common. The other is toxic multinodular goiter or toxic adenoma, thyroiditis, and there will be an excess iodine. Coming to the secondary hyperthyroidism, there will be an TSH stimulating pituitary adenoma. It's a rare condition. So for this pathogenesis of the Graves hyperthyroidism, there will be rise in T3 and T4 causing beta adrenergic activity, which will lead to rise in BMR, that is basal metabolic rate, which leads to increase in the oxygen consumption and heat production. So coming to the Graves' disease, it is an autoimmune disorder causing TSH receptor stimulating antibodies. Once again I will repeat. Graves' disease is an autoimmune disorder causing TSH receptor stimulating antibodies. In Graves' disease, we will see the redness and bulging eyes as a clinical feature. The pathogenesis of the Graves' disease, it is an autoantibodies like TSI and TRAB binds to the TSH receptors, causing continuous stimulation of the thyroid gland, which will lead to rise in T3 and T4, and this will lead to a decrease in the TSH. So always to remember that in primary hyperthyroidism, there will be rise in T3 and T4 and decreased TSH, that is thyroid stimulating hormone. So as we discussed earlier, Graves' disease, it also acts on the orbit like Graves' ophthalmopathy on skin in pretibial myxedema. Pretibial myxedema means it is an orange discoloration on the shin initially. So Graves' ophthalmopathy, it is an autoinflammatory disorder of the orbit associated with Graves' disease due to antibodies against TSH receptors on the orbital fibroblast. So pathogenesis, we discussed earlier, it will bind to TSH receptor antibodies causing activation of the orbital fibroblast, which will lead to raised glycosaminoglycan deposition causing edema and the enlargement of the extraocular muscles, which will lead to raised IOP, means intraocular pressure, causing propoptosis and the optic neuropathy. Remember that there will be an increase in glycogen deposition. So this point might be asked in your theory exams. And the risk factors of the Graves' disease are the smoking and radioiodine therapy. So for the classifications of the Graves' ophthalmopathy, we will remember no specs as a mnemonic. So for the grade 0, N, no signs or symptoms, and for the grade 1, only signs but no symptoms, there will be lid retraction, stare or lid drag. And for grade 2, there will be a soft tissue involvement like periorbital edema, conjunctival redness, chemosis and the lacrimation. Lacrimation means there will be tears in the eyes. And for grade 3, C, propoptosis, means forward protrusion of the eyeball. And for grade 4, there will be an extraocular muscles involvement, means there will be an restricted eye movements, and the diplopia means double vision. And for the grade 5, that is corneal involvement, there will be an exposure keratitis and corneal ulceration. And for the grade 6, there will be a sight loss, optic nerve compression, which will lead to decrease in the vision. Remember that for this mnemonic, it is no specs. And for the severity, there will be mild for grade 1 and 2. And for moderate to severe, there will be grade 3 to 5. And for the severe, that is side-threatening, grade 6. For this management of mild disease, we will first stop the smoking cessation, and the second one we will given as a lubricating eye drops, and third one is the selenium. Sometimes we will give. And for the moderate to severe active disease, corticosteroids is the drug of choice. It might be asked in here in the MCQs, so please remember that. And orbital radiotherapy. And for the side threatening, there will be an orbital decompression surgery if it's severe. So remember these 3 points. Sometimes they will be asked in your MCQs. So if the question paper on most common sign of the Graves ophthalmopathy is the lid retraction. When someone asks is the most common sign in the Graves ophthalmopathy means lid retraction. And for the Graves ophthalmopathy, the most common symptom is foreign body sensation or creatiness. When the examiner will ask the complication of the Graves ophthalmopathy, that is the most serious complication, means it is an optic nerve decompression. So for the optic nerve decompression, as we discussed earlier in the management, the surgery is orbital decompression surgery. So this is orbital decompression surgery for optic nerve compression. And the clinical features of the hyperthyroidism, there will be a serious palpitations, CNS and fight tremors, and there will be sweating, hyperactivity and irritability. And there will be weight loss due to BMR is increased, and there will be heat tolerance in primary hyperthyroidism. Remember that the most clinical feature, important clinical features we have to write in the theory exams, heat intolerance. And for the female, it's oligomenorrhea, infertility, proboptosis. And for the cardio, there will be a tachycardia, that is raised heart rate and atrial fibrillation. So on Graves' disease, on the examination, we will see von Graves sign or lid lag of the upper eyelid and downward gaze. See, lid lag of the upper eyelid and downward gaze. This is pretibial myxedema on examination. As we discussed earlier, there will be an orange discoloration on shin. So on examination, sleeping pulse rate is increased, that is resting tachycardia. There will be pretibial myxedema. So as we discussed earlier, it is an orange discoloration on the shin initially. Myxedema is a non-pitting in nature. Do remember that it might be asked in your theory exams. And for the Graves ophthalmopathy, it is due to the contractions of the malleus muscles. It is a sympathetic overactivity. And the lid lag sign or stay sign, it is an earlier feature. We might be seen as an inadequate blinking. Inferior rectus is the most common extraocular muscles is involved. Remember that these might be asked in your MCQs on theory exams. Which extraocular muscle is involved on the Graves disease means inferior rectus. Okay, so sometimes this might be asked in your MCQs like these questions. First one, we will take the medical history and the physical examination. And the second one is we will do a thyroid function test. In thyroid function test, there will be a raised T3 and T4 and decreased TSH as we discussed earlier. Now, and sometimes we will do anti-TSH receptors antibodies, and we also do CT or MRI orbit for muscle belly and enlargement tendon sparing. Sometimes we also do radioactive iodine uptake test. In radioiodine uptake test, when the examiner will ask diffuse increased uptake means it is a Graves' disease, and for the patchy increased uptake means it is a toxic multinodular goiter, and for the low radioiodine uptake there might be a thyroiditis and fasciitis. We also investigate the fine needle aspiration biopsy to diagnose the hyperthyroidism. So coming to the management, so for anti-thyroid drugs, we will use methimazole, drug of choice, safer during in the second trimester pregnancy, whereas in the prepared thiouracil, it is preferred in the first trimester pregnancy, and the side effect is agranulocytosis and the hepatotoxicity. So for the control of symptoms like symptomatic relief, we will use beta blockers, that is propranolol. So for the radioactive iodine uptake, it is a definitive treatment. It is contraindicated in the pregnancy, breastfeeding, or incontinence. So radioactive iodine intake, it is indicated during toxic multinodular goiter or Graves' disease, and we also do sometimes surgery. See, it is indicated in large goiter, uh, or it may be during a tract failure, or we also indicated during the malignancy suspicion. Thank you.